Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome to another protocol review module. Today, we're talking allergic reaction and anaphylaxis, so let's jump right in. There are two big points I want to make. First, anaphylaxis is Latin for needs more epi. The treatment for anaphylaxis is epinephrine. Let me say that again. The treatment, or the antidote, if you will, for anaphylaxis is epinephrine, not steroids, and definitely, for the love of all that's holy, Benadryl. Epi, and I'm sorry, what's that you said? Oh, that's right, more epi. The treatment for anaphylaxis is epi. Second point I want to make is the most common failure in the treatment of anaphylaxis is the failure to suspect and diagnose it. So, point one, treat anaphylaxis with epinephrine. Point two, suspect anaphylaxis in all allergic reactions. Now, that doesn't mean you're going to find it or that it's there at all. But the one certainty is that if you don't suspect it, you won't diagnose it. As the saying goes, the eyes don't see what the brain doesn't know. With that in mind, let's cover how to diagnose it. Now, we typically think anaphylaxis means anaphylactic shock. And while that shock is definitely anaphylaxis, no doubt, it doesn't have to be shock. What it does have to be is acute and brought on by an allergen. An allergen, well, y'all know what an allergen is. It's something the person is allergic to. Sometimes it'll be obvious. Sometimes we won't figure it out, but we gotta at least think about it. Now, here are the criteria for anaphylaxis. These are spelled out in the white section at the bottom of the protocol, but to review it, there are basically two criteria, two pathways. Number one is exposure to an allergen and acute onset of hypotension. That's number one, all by itself. You get hypotension, allergen, boom, anaphylaxis. But, wait, there's a second, and that is exposure to an allergen and an acute symptoms from two or more of the following systems. System one, respiratory, that'd be your wheezing, the shortness of breath. Two would be cardiovascular, which pretty much means hypotension. Three would be gastrointestinal, and that's mostly diarrhea or vomiting. And four, integumentary, or the skin, and we're talking hives here. So let's go over a couple of scenarios just to make sure that we got this. Scenario number one is someone is allergic to wasps. Make that cats. Someone is allergic to cats and they get, I don't know, attacked by cat hair. And then they are all puffed up like, say, the Michelin Man. They are one big hive. They have stridor. They have wheezing. They are hypotensive, tachycardic, hypoxic. They have vomited and pooped all over the place. And just for good measure, there is a large neon sign over their head flashing anaphylaxis in not one, not two, but three languages. So there's not much doubt here. This clearly meets anaphylactic criteria, and it needs, I'm sorry, what's that? What does it need? That's right, it needs epinephrine. All right, so that's one scenario. That's the obvious scenario. Let's get a little more complicated. All right, so the next patient, well, let's say they're allergic to strawberries and they accidentally ate a strawberry. Now, they have normal blood pressure, but they have hives and they have wheezing. That is two body systems, integumentary and respiratory, hives and wheezing. What is it? It's anaphylaxis and it needs epi. All right, next scenario, same strawberry eating dude, same normal blood pressure. Now, diarrhea and hives. Yep, GI and integumentary, GI and skin, two systems, anaphylaxis, needs epi. All right, strawberry guy, back again, same normal BP, now with diarrhea and wheezing. Two systems, GI, respiratory, anaphylaxis, needs epi. Let's talk Benadryl and steroids. Think about these as the window dressings of anaphylaxis. Sort of nice, but not necessary. Epinephrine is necessary. not so much on the steroids or the Benadryl. And specifically, I don't want you to let Benadryl or steroids distract you from giving epinephrine in anaphylaxis. Please don't do that. Bad, your patients would not appreciate it. Since we're discussing how important epinephrine is, I should probably mention that we've changed the dose of IM Epi to make it easier to give more accurately and easier to draw up. Plus, did I mention Epi is what anaphylaxis needs? Good, I think I might have. So the IM dose, and not sub-Q dose like I was taught back in the dark ages, all the way back in the last century, not sub-Q. IM, intramuscular. It's 0.5 milligrams. That dose again is 0.5 milligrams. IM, not 0.3 milligrams sub-Q. 0.5 milligrams is the IM dose, and the IM dose shall be 0.5 milligrams. I hope you all heard that because it might, just might show up in a question that you're going to see shortly. So that is the important life-saving stuff. Now let's discuss allergic reaction and symptom management. Now, the spectrum of disease with allergic reaction, it goes from allergic reactions of various severity all the way up to anaphylaxis. We've certainly talked about anaphylaxis. We know that that needs epi, and we can certainly treat the less severe forms of allergic reactions without epi. But anaphylaxis always needs epi. With that out of the way, let's discuss the other stuff. For localized reactions like hives, feel free to give diphenhydramine or Benadryl. The dose is the same thing you'd take at home, 25 to 50 milligrams orally. And then obviously watch for progression. For wheezing or signs of bronchospasm, do what you would do for other wheezing and bronchospasms, albuterol, ipratropium, Doneb. For more severe allergic reactions that still don't meet the criteria for anaphylaxis, and basically we're talking here severe allergic reactions without anaphylaxis, that's basically going to be severe respiratory symptoms. These are things like stridor, respiratory failure, oral pharyngeal swelling. What do you suppose we're going to give there? That's right, we're going to give epi, and we're going to do it 0.5 milligrams IM. Now, if you're on a BLS unit without a paramedic and you've treated a patient with epi, but they don't want to go to the hospital because you fixed them, they're feeling better, strongly urge them to reconsider and let them know their symptoms can actually rebound and come back. It's a distinct possibility. They need to understand that to make an informed refusal decision. So that's the allergic and anaphylaxis protocol for basics. If you're credentialed at the basic level, feel free to drop off. Take the quiz, go back to doing whatever it was you were doing. If you're a paramedic or critical care paramedic, however, stick around for the other parts of the PRM. And if you're a basic and you just want to know more, or maybe you're hoping my daughter's cat makes another appearance, feel free to stick around. It's only about a minute or so more. Thanks and take care. All right, welcome back. Let's talk paramedic stuff. First and most importantly, did I mention the treatment for anaphylaxis is epinephrine? To be clear, epinephrine is not the generic name for Benadryl or Decadron. You'll know that. Please don't get distracted by other drugs when the one your patient, well, your partner may be crying out for it too, but I'm talking patients here. Your patient crying out for epi. Now, once that's in, go for the steroids, the Benadryl, that's great, but please don't do it before. All right, at this level, we've added IV treatment in. IV epinephrine in this protocol for anaphylaxis is given by two options. First is push dose epi, and it's given the usual way, 10 mics. Just, get your 1 to 10,000, draw up a milliliter of that, dilute it in 10 milliliters of normal saline, and you give it 10 mics at a time. Now, we've also added an epinephrine infusion. That's starting at 5 mics a minute, and titrated up to a MAP of 65. MAP 65 or greater. Now, the epi infusion, obviously, that infusion is going to be used only for hypotension. Nova, my daughter's cat, clearly got excited about this conversation. Lots of people are allergic to cat dander, but they don't have anaphylaxis. And if that were the case, if you are so allergic to cat dander that you are itching, having a runny nose right now, just watching this, you might be tempted to take Benadryl, and that's a perfectly reasonable thing to give. Go ahead and treat it IV, IM, IO, or PO, same dose that you would doing it orally. That's 25 to 50 milligrams. You can also give dexamethasone, 10 milligrams IV or IM. The pediatric dosing of these drugs, it's listed in the protocol. Please don't try to memorize them. Just do what I do and look them up each time. Will you stop taking my stuff away? Look them up each time. All right. Thankfully, the cat and my daughter, who's not helping here, the cat is telling me it's done. That's it for the allergic reaction anaphylaxis protocol review module. To sum up the important bits, let's hit it one more time. Anaphylaxis needs epinephrine. Anaphylaxis needs epinephrine. The cat with anaphylaxis needs epinephrine. The most important reason for not giving epinephrine is failure to recognize anaphylaxis. Remember the criteria. See, I told you it was only another minute or so. That's it. We're done. No moss. Thanks for watching. As always, thanks for watching, and thanks for what you do. Take care, y'all. Cat? Yeah. Yeah. Uh-huh. Are you going to hit my record? You're going to stop the recording, aren't you?